Hello, everyone, and welcome to the Guthy-Jackson Charitable Foundation Education Center and the NMOSD Grand Rounds series. We welcome all in attendance and remind that the Guthy-Jackson Charitable Foundation is proud to be a source of information about NMO and related conditions. The content of the following presentation is based entirely on published data and expert opinion. GJCF is not a clinical provider. It does not offer or represent diagnostic, therapeutic, or clinical care recommendations or advice on personal health. All patients and caregivers are advised to consult with their healthcare team for specific information. The NMOSD Grand Rounds series has several overarching goals. Each episode is designed to offer practical summary of latest information on a specific topic. It's designed to emphasize key themes and clinical pearls that we hope are useful. It's also intentionally inclusive of non-specialist audiences, with the idea that the information here may be broadly applicable to helping patients and caregivers. And finally, at the end of the presentation is a pocket guide that we hope serves as a helpful reference. This presentation qualifies for continuing medical education activity. To receive credit, please visit the GJCF Education Center using the QR code shown here. Select the session of interest and register for that session. View the session and fulfill the CME requirements and receive the CME certification online. My name is Dr. Michael Yeaman, and I'm Chair Advisor to the Guthy-Jackson Charitable Foundation. We are delighted today to introduce Dr. Hina Garg. Hina is Associate Professor in the Department of Physical Therapy at the Rocky Mountain University in Provo, Utah. She's also the director of the Physical Therapy and MS Wellness Center in Provo. Dr. Garg, thank you so much for your presentation today. We look forward to learning a lot about your topic, Moving to Mobility, Physical Therapy and Rehabilitation in NMOSD.
Thank you, Michael, for introducing me. And I'm delighted to be here. And having worked as a physical therapist and the director of the MS Center, I have seen the firsthand impact of physical therapy, rehabilitation, and wellness in individuals with NMOSD. Therefore, I'd like to highlight a few key aspects in this presentation and start with elaborating on the role of physical therapy in NMO, maybe mention some exercise recommendations, the recent evidence on the role for physical therapy in NMO specifically, highlight some of the treatment paradigms that the physical therapists work with. And then I'll move into the exercise considerations for strength training, balance coordination and gait training, cardiovascular training, flexibility training, and certain considerations specific to, as you know, of NMO, such as vision adaptations and managing fatigue. And then finally, I'll move into the conclusion and key takeaways from this presentation. So very briefly, as we know, the NMOSD is an inflammatory demyelinating central nervous system disease, which can affect the pathways of optic nerves, spinal cord, and other areas of the central nervous system. This can clinically present as impairments in mobility, strength, and vision, and or stamina in individuals with NMOSD, which all in turn can affect their overall quality of life. Therefore, needing neurological specialty physical therapy, rehabilitation, and exercise to manage and improve symptoms. In this presentation, thus I'd like to provide some clinical examples and evidence that highlights the role of early rehabilitation in individuals with NMO. Three major points to consider are that early physical therapy and rehabilitation have shown to reduce secondary complications and promote neuroplasticity. Second, it has also shown to enhance mobility, balance, and quality of life outcomes. And lastly, preliminary research shows improvements in impairments and functional limitations, even if neurological disability within different functional domains stays the same. Since the evidence is still preliminary in the field of rehabilitation and NMO, I would like to draw from some exercise recommendations for individuals with MS. There have been a multitude of studies that have shown exercise and physical activity reduces fatigue and improves endurance, muscle strength, balance, and overall quality of life in people with MS. So the current physical activity fitness parameter recommendations in MS, typically for individuals with minimal disability, include exercising for aerobic capacity, for resistance, as well as for flexibility. Let me highlight a little bit about the aerobic capacity. So individuals are recommended to exercise for 3 to 5 days per week at least a moderate intensity, defined as rate of perceived exertion for 12 to 13 on a scale of 6 to 20 for Borg exertion scale. Exercise could be as minimum as 2 minutes of activity, even if it's moderate, or 60 minutes of activity. And it could be spread throughout the day in multiple intervals. Typically, aerobic exercise would include large muscle groups and rhythmic motions. For resistance training, it's recommended that the exercises are included for 2 to 3 days per week at a 65 to 75% one repetition maximum. And this repetition maximum is not the significant load that you can push for one repetition. It could be as much as 3 rep max or an 8 rep max established for these individuals. Minimum of one set of 10 to 15 reps, 8 to 10 exercises, large muscle groups are recommended. And lastly, it becomes important to address spasticity and pain in these individuals if flexibility is an issue. So that is another component of exercise, where 2 to 3 days per week, from static, progressive, holding the stretch type exercises to progressive, dynamic stretching could be recommended if they don't have a lot of spasticity. But typically, holding the stretch for 60 seconds per muscle or joint, and sometimes facilitating different muscles during the stretch are recommended. So that is what that PNF is, proprioceptive neuromuscular facilitation type stretching, progressing through that end range as best as you can. In moderate to severe disability with MS, on the other hand, an article by Koenig 2022 found the need to design specific behavioral approaches to address the physical and environmental barriers to physical activity participation for these individuals with moderate to severe disability, and they may not meet these criteria for minimal disability and exercise recommendations. Some of these barriers, as listed by other authors, Learmouth, include personal physical barriers such as ambulatory disability, fatigue, depression, and environmental barriers such as a lack of accessible facilities and insufficient advice from the healthcare professionals. Authors found that PT is not enough to improve physical activities in these individuals with advanced disability. Therefore, the recommendations may need to be modified with including individualized prescriptions for the exercise type that they can tolerate, the difficulty level, as well as the sets and repetitions for that specific patient. And the minimum of twice per week still holds true for maintenance of fitness for these individuals. Now, in a study by Dongmei in the year of 2019, 39 patients with NMO with moderate to severe disability, where the EDSS was found to be 7.5, were randomized into intervention and control groups, and they were assessed on their EDSS score, the disability score, and functional system scores after 4 weeks of rehabilitation and 3 months of follow-up. The intervention group received a multitude of interventions, including physical therapy, rehabilitation, range of motion, strength, hand transfers, balance, and gait training. 30 minutes daily, which was a good amount of time per day, 5 times per week for 4 weeks in the hospital. And then they were given some home program for the community and home-based rehab to continue for 3 months. And occupational, cognitive, respiratory, and phonetic therapy were also given when necessary. So that is the multitude of rehabilitation interventions that were given to these set of individuals. And they were compared against a control group who didn't receive any interventions. Improvements in the disability status score and certain domains of bowel, bladder, and motor functions were noted after that multidisciplinary rehabilitation. And the key point here is as you see in the graph, the intervention was effective as early as 4 weeks after during that hospital stay and after the intervention period for the intervention group, versus the control group didn't see those kinds of changes. The changes that they started to see were after 3 months of doing their usual activities. So in this slide, the key message would be that multidisciplinary rehabilitation can be useful for an early recovery for NMO. In a prospective cohort study by King and Lee in 2022, the 36 individuals with acute NMO who were admitted to a hospital received rehabilitation exercise in addition to medical treatment, and they were compared to a cohort of 37 individuals who only received the medical treatment by choice. Rehabilitation exercises included strength, aerobic, ambulation, postural transfer training, and balance training, at least at a moderate intensity, for 30 to 60 minutes per session for 5 times per week. And improvements in nervous system function using the EDSS scores was seen, and balance, as well as for activities of daily living using the Barthel Index. The key point on this slide is that individuals can start exercising and participating in rehabilitation as per their capacity as early as day 1 of admission to the hospital during an acute episode with NMO. And they performed the rehabilitation well all the way to discharge without many adverse reactions beyond minor reactions such as soreness or fatigue, which was monitored during the study. So this indicates that patients with NMO can improve their neural dysregulation and start using neuroplasticity following an acute episode of NMO. So in the next slide, I want to highlight the treatment paradigm the physical therapists work with. We start with an initial assessment where we sit down with the patient and address their chief complaints. What are the outcomes that we would like to select in our examination to highlight those complaints, as well as monitor and progress their rehabilitation towards their goals. Also pick up on any occult signs or comorbidities such as fatigue or pain. And then establish some goals, generally linked to the WHO ICF model of impairments, function, and participation. Moving on to the intervention of where we choose from our different treatment techniques that we have available to us, including balance, gait, strengthening, range of motion, flexibility, neuromuscular re-education, etc. And that's followed up with a reassessment of those outcomes on strength, balance, neurological disability, quality of life, whatever the person presents with. So overall, this entire treatment paradigm allows us to move from initial assessment to a reevaluation and determine whether the person is able to progress towards their shared and established goals with the therapist. From the previous slides, hopefully you can see how a physical therapist can address all the symptoms that an individual with NMO could present with. Motor weakness, visual deficits, especially as they pertain to gait and balance, spasticity or stiffness, fatigue, sensory changes, pain, dizziness, and other problems with balance and coordination, walking and arm and hand function, and hopefully overall quality of life. I also wanted to highlight a framework by Bello Haas for rehabilitation of neurodegenerative diseases that provides guidance on how to approach patient care along the continuum from an early to the late stages of disease progression. So by staging these diseases and relating them to the individual's impairments, functional limitations, and disabilities, the framework serves as an organizational tool for planning interventions for the neurological physical therapists. There's different strategies that have been proposed that include intervention, consultation, education, or preventative, compensatory, and restorative interventions. The whole point is that this continuum allows us to consider the continuum of care for our patient as the patient progresses through different stages of the disease. Now, as an example, within the early stage of the disease, the therapist will expect to find few impairments, physiological or structural, none to minimal functional or quality of life issues, therefore none to minimal disabilities. At this stage, the therapist will first conduct a baseline exam and focus on preventative and educational strategies to help them manage the condition for the future as well. In addition to providing some restorative therapies such as strength training or fatigue education for symptoms, but may not include any compensatory therapies such as use of assisted devices. These strategies get reprioritized and reorganized as the person progresses through their condition and presents with different impairments across middle as well as late stages of the condition. So moving into different types of training that a physical therapist will engage with for a person with NMO. The first is strength training, which allows us to overcome weakness and optimize functional mobility in arms, legs, trunk, etc. These trainings could include seated exercises, standing exercises, use of resistance bands, use of weights, free weights, use of pulley systems, just different types of strength training mechanisms overall to improve the strength of upper extremity or lower extremity for the individual with NMO. Now, there's been a case report, mostly case reports, which have elaborated specifically on these training techniques. So I'll highlight this one case report where physical therapy intervention specifically for a 13-year-old individual during hospitalization with NMO included strength training and balance training using virtual reality. They found significant improvements, the best they can for a case study design. So the nature of this design, therefore, allows us to be cautious when extrapolating these findings. The progressive resistance training for the upper extremity and lower extremity was given for 5 days a week for 2 weeks. And the balance training specifically when using virtual reality was provided in a constraint-induced manner so that they used the weak extremity first in performing any of the tasks that were given to them. The improvements were seen across the board, as I said, for strength, quality of life, and function. And they were pretty drastic, where the person improved from a 2+ strength on the MRC scale to a 5 out of 5 strength on the MRC scale. The next type of training would be balance, coordination, and gait training. Now, that's a lot, that could be the entire session sometimes, where individuals would be exercising either in seated balance exercises, standing balance exercises. They could be using their assisted devices as well as not using assisted devices, different surfaces, eyes open, eyes closed, so that they can rely and re-weight their entire nervous system and rely on different sensory strategies to maintain their balance. Same goes for coordination and gait, different environments and repetitive motions to ensure that individual is progressing towards each of those components. The key aspect here for individuals with NMO would be adapting for the limited vision, so including different types of feedback, auditory cues, or tactile feedback to facilitate the balance and coordination and gait for this individual with limited vision. And then also adjusting the adaptive equipment as the person progresses through different components of these training, allowing them to use canes, to walkers, to different mobility devices, and also educating them in using these devices through the day for the entire week as needed so that they can continue to manage their balance and walking ability without feeling extremely fatigued. So just examples of certain exercises, as you can see on the right side of the slide. So these are some examples of the assisted devices that can be suggested, prescribed, and changed and switched over from across the disease spectrum from the early, middle to late stages. I've included some pictures over here. The idea for many of these devices is not only to sometimes guide them in their balance. It could be as simple as guiding, sometimes for compensation of the weak areas so that they can rely on the mobility device for strength as well as balance. But then also for different mobility devices, we want to make sure that they understand how to switch across these devices and be safe in the community and environment. And for prolonged sitting in the wheelchair, especially, we want to educate them on prevention of secondary complications such as a contracture, the pressure wounds, pneumonia, and then family and caregiver education on safety, positioning, transfers, skin care, as well as how to turn and switch between these devices. These examples continue. There's so many that I've listed on these slides. And just to point a few, if you could look in that bottom right, where we have this person in a harness, I have a body weight supported system training where I put the person in a safety harness and get them going from bed to standing to different types of walking devices. Devices could be as simple as more for compensation, like that leg lifter, where the individual, if they have a significant hip flexor weakness, they're not able to lift the leg up onto the bed, then they can use a leg lifter device so that they can go ahead and put that leg on the bed and bring it back down as needed. Or, as I pointed in that body weight supported treadmill training, where or overground training, where I can use the device for more restoration or training purposes and not just compensation. So this is another study for giving you some evidence on high intensity gait training that was actually tolerated very well in a person with neuromyelitis optica, and there were some recommendations that were made. The training was highly elaborate, and I've given you just one example of how the individual was taken from bed mobility transfers, ambulation to stairs, and per week breakdown on that graph on the right side. It was well tolerated, and there were substantial improvements in gait balance and function. However, again, it's a case report, so we have to be cautious in inferring these findings to a larger section of the population. And then there's cardiovascular training, which could be as simple as low impact activities, including hand or seated motions. Typically could be given in the form of interval training if the person cannot tolerate continuous training, as I had mentioned on previous slides. There's also some education on pacing these activities, and you could use many adaptive equipment as along with these activities, like using a tricycle or using a hand wrap to keep that grip onto the device if they need to be able to continue to cycle for a few minutes where their hand may be very weak to hold on to that grip. So there's some examples that I've given you for different kinds of devices. And lastly, flexibility, tone, pain management in individuals with NMO. That requires a little bit of creativity in determining where the lack of range of motion is coming from. Is it from tightness and inflexibility, or is it from spasticity? Or is it from, is pain a factor for poor mobility? So there's a lot of things that go into determining that during the evaluation. And overall, the therapist might be working with improving flexibility, giving stretching, as well as improving on tone, working with the medical treatment, of course, at that time to manage spasticity, and prolonged stretches generally help. Positioning helps as well. And then managing pain to identify where that pain is coming from. Is it from muscle, ligaments, other tissues, or joints? And somehow, come to this creative set of exercise routine to reduce the stiffness, pain, and discomfort for the individual and overall enhance their daily function. And these exercises could include all of those. Seated, standing, specific joint exercises, just so much that goes into when the person sits down and creates a goal with the therapist. With NMO, it becomes very important to have visual adaptations for exercise. So making sure that the instructions as well as the visual cues are clear for better visibility and positioning for safety during the exercises. Tactile markers could be used to help participants locate the equipment and maintain orientation. And then ensuring a controlled and safe environment, allowing them to mitigate fall risk because of poor vision. That's one major factor, especially for home program as well. And the last thing to consider is managing fatigue and exercise for our patients with the NMO and energy conservation techniques such as pacing and scheduling breaks to manage the levels of energy during the day, during the week, as well as throughout is has been proven to be pretty effective in my clinical experience. Daily, weekly planning of the activities and recognizing signals, also for signs of fatigue or discomfort, and educating them for when to stop to avoid that worsening of that fatigue, because the issue becomes recovery from that fatigue, from that extreme exertion, and also detecting if there's any exertional intolerance in the individual so that you're not putting them through a highly intense environment, especially when exercising, which allows them, which limits them in their recovery, and they may have like long episodes of in bed time or sedentary time after, just to recover from that exercise session. And then also keeping in mind for fatigue, different sources of fatigue that might be causing issues in the individual, such as diet, hydration, sleep, and really breaking down those sources of fatigue for the individual. Therefore, PT could be very creative, directed, and intentional for individuals with NMO. Just some pictures to show that. And I just want to highlight a few resources for NMO, and there's some professional organizations such as the Guthy-Jackson Charitable Foundation, the Sumaira Foundation, SRNA, and neuromyelitisoptica.net. I do add a little bit on the PT experts, and then I encourage individuals to always seek support groups, local as well as online, to connect with other individuals, because PT sometimes is not enough, and that wellness component becomes very important for individuals with NMO, so that they can foster a good community and seek that emotional support for themselves as well as their caregivers. So lastly, this is a slide, hopefully, highlighting all the clinical pearls from my presentation. And the first one is that multiple components of physical therapy, including aerobic, strength, balance, gait, training, as well as education, were found preliminary effective in individuals with NMO. Most of the evidence is in the preliminary stages, where you've seen maybe one randomized study, maybe a couple cohort studies, and a few case reports. So I think we are drawing a little bit upon the other conditions such as MS to inform our clinical practice for patients with NMO. Second, individualized exercise regimens and early intervention specifically tailored to each individual's unique capabilities are highly recommended. I believe that individuals with NMO sometimes may have significant clinical presentation disability at the beginning, but they tend to perform very well throughout the rehabilitation and seeing changes drastically well as early if intervened early. So I would recommend that for everybody. And third, regular evaluations and collaboration with PT for ongoing assessments are needed. Because of the progressive sometimes and the relapsing, remitting nature of the condition, just that contact with PT to ensure that their symptoms, as they're coming up, that they're taken care of as they can, with the help of a physical therapist, just like any other medical member of their team. And interdisciplinary coordination is critical. Just highlighting that point of that I've given you, I think, a couple studies with that interdisciplinary component specifically being very helpful for individuals. So I think that becomes critical for the team and the patient. And encouraging safe and regular physical activity, where thinking about how to integrate them back to the community and making sure they're well as needed throughout that disease spectrum. I've also prepared a pocket guide that highlights key points from this presentation, and it hopefully should serve as a reference guide for the role of physical therapy and different components of our treatment sessions and rehab in patients with NMO.
Dr. Garg, thank you so much for an excellent presentation and overview of physical therapy and rehabilitation in NMOSD. We have some time for questions, so why don't we just get right to the first one? So what kinds of symptoms in NMOSD most commonly interfere with a patient's mobility? And how might we prioritize those symptoms in the rehabilitation strategy?
So individuals typically could present with the lower extremity or upper extremity weakness, spasticity, sensory loss, imbalance, and fatigue, and those symptoms tend to affect the person's mobility quite a bit, because when they come into the clinic, they mention how the vision has been a factor, but then also how walking is becoming difficult. So the role of the physical therapist becomes then in their interview with the patient or in their examination specifically to figure out if it is a weakness or the sensory loss or the spasticity that's causing that mobility problem. So I think it's that picture that you would want to explain how the mobility is for that person. And then the priority is really established by the patient as well as the provider within their shared decision-making process in the rehabilitation. So if the individual chooses to have balance and walking ability be primary as their goal, then I go ahead and address in my examination what are the factors causing that imbalance and mobility problem, and then go on from there.
That's really important because, as you emphasized in your talk, customizing the program for the patient affords the best outcome. And in that sense, different patients are of different ages and different physical abilities just naturally. So can you just say a few more words about that kind of customization?
Sure, aging is a significant factor for most of the neurological conditions, especially when you have this relapsing, remitting, as well as progression in between. And making sure that in your examination, you're aware of factors such as if there's any osteoporosis or other factors that would be very specific to as a person has progressed within their age. And just including those components in your examination, in your interview, even cardiovascular risk factors as a person ages, they may see certain comorbidities, right? Like hypertension, diabetes, etc. And you want to incorporate all those factors of postural issues that start to develop with different kinds of, with different ages. So I think keeping all of that in mind in your interview, as well as in that examination selection process for what outcomes become very important for this individual at this point in time, and then educating them as they live well with their condition, as they age well with their condition, also addressing any restorative treatments at that point. So I really have to make sure that I address the in time, issue that they're presenting with, but also educate them for how to progress well.
That sounds great, Hina. Why don't we go to the next question, which has to do with when should a patient with NMOSD begin physical therapy and what signs indicate that they're ready to start? We know that an onset episode or a relapse event can create greater issues with respect to disability than might be during remission. So when should physical therapy begin, and in what sense regarding signs and symptoms?
And that's a great point. Like for acute inflammatory phase, typically we want that to be stabilized. We don't want an individual to be exerting a lot during that episode of relapse. And you want that phase to be very light for that individual, allowing them to have good recovery. So therefore, if you want to think about it as acute relapsing phase versus remitting phase, when does physical therapy need to be? I tend to say when the acute phase has stabilized and they're in the remission process. Generally, light activity is only recommended, usual activity, typically recommended during the relapse phase and giving them most recovery time as possible. But once they're in the remission, physical therapy is a great time. And signs and symptoms typically would be any absence of new neurological deficits or worsening neurological deficits indicating that they have stabilized, or the ability to tolerate some exertion and physical therapy. And I think sometimes that is a little bit hard for individuals because they feel like they're going to be exercising and they're going to get worse. But sometimes it's as simple as I'm very fatigued, and can a physical therapist help me identify my sources of fatigue, or help me manage my fatigue as I get through the day, because that is still physical activity. Okay, so it doesn't have to be like pushing them to the point of exertion, high intensity exertion. So early start is always better, as long as it's medically stabilized and appropriate, because it allows for limited deconditioning and secondary issues.
Thanks, Hina. And are there applications? I'm thinking about the usual kinds of things that occur in physical therapy or rehab medicine, such as icing or anti-inflammatory meds, are those things that you normally think about during these kinds of treatments?
Yeah, if I need to use icing or any other heat modalities or even pain relieving modalities, I tend to bring those up for the person for sure. Electrical stimulation is a great example. I use electrical stimulation devices. It could be, let's say, electrical stimulation during a functional activity like biking or during sit to stands, or sometimes as simple as electrically stimulating a weak muscle so that they can do an assistive activity with me. So that's one another example. But heat and icing as needed if the person presents with pain, it becomes important where, where that issue is coming from and if I can use a modality to assist.
Excellent.
Yes.
Well, speaking of fatigue, I think the next question gets a little deeper into that, and that is, how does a physical therapist assist in managing severe fatigue, which in and of itself can often be a major barrier to rehabilitation?
Yeah, and I would agree it is a significant barrier to rehabilitation because we have to first identify if the person is uh, tolerating any form of exertion well, if they're tolerating their usual activities well or not. So the first step really is to listen to the patient and evaluate where the sources might be coming from for that severe fatigue, because sometimes it's medical issues like anemia, sleep disturbances, or side effects of medications, or some other factor like uncontrollable pain, for example, or doing certain activities and or pushing themselves to the point of severe fatigue that they are recovering for a week. So trying to identify where that source is it medical or non-medical? And by non-medical, I mean well, medical could also include just the primary nature of the condition. Non-medical could be deconditioning and other factors, right? So I do think like therapist needs to first evaluate to a great degree and then employ strategies for how to overcome that severe fatigue in a low to a there's a spectrum of low to high intensity that they can tolerate, but the therapist has to work with the patient to understand where this individual might be in their disease stage and what type of tolerance can they handle for fatigue management strategies, because some of the strategies could be exercise related versus some could be education about the medical issues that they're having and referral versus some could be as simple as energy conservation pacing strategies. So I think the strategy depends upon the evaluation.
Thank you so much. And may I just ask a related question? And that has to do with your point about the need for interdisciplinary teamwork in providing care. Severe fatigue is often linked to depression or anxiety or other sort of mental wellness factors. Can you say a little bit more about how you differentiate between fatigue, physical fatigue, and sort of emotional or mental fatigue that presents as depression, for example?
Yeah, and that's a great question because I do talk to them about different types of fatigue, where I ask them specific questions about if they're able to sustain a physical activity for a longer duration or not, and if that's when they feel their fatigue. It's at the onset of the activity or after holding the activity for a certain time. Is it accompanied with other symptoms like pain, etc.? Or is it maybe emotional or psychological, where emotional could be social factors as well? So I think asking them which kind of activity and educating them. Is it after talking to a person on the phone for a little while? Is it on a mental activity that they're looking at a screen for a little while or reading for a little while? And that's when the fatigue sets in. So again, that listening to the patient and trying to break it down to understand where that fatigue source is coming from. And if it is within the scope of my physical therapy practice, educating them or referring them as needed. And also like modifying activities is definitely something that I do with them. So having that explanation and education makes a huge change in their lifestyle.
Great. Thank you so much, Sheena. We want to kind of look a little bit more at the next question, which has to do with you pointed out some excellent sort of results in the structured physical therapy and rehabilitation sort of facility environment. The question is, of course, how can we help patients continue safely doing these kinds of exercises and applications, as you said, that help maintain mobility gains after the formal therapy ends?
Yeah, and that's a great point because I've seen clinically as well as read enough studies where individuals tend to not hold the gains that they achieved during rehabilitation one-on-one sessions when and you see a drop off in those gains when they transition to home exercises only. Therefore, education becomes a huge factor at the start of the session. In my first one-on-one session, I am examining and educating them as I'm going and emphasizing the importance of managing their condition on their own, well, with guidance from me. So if I am able to highlight that point and make it very doable for them for that initial session, as well as a few follow-ups that I schedule with them, that they can own to that home program, have that home program and understanding from education, from the first session onwards, they take it home and I ask them review it every single time I see them at that regular follow-up for how did that go, and go ahead and show me and go ahead and point it to me for how you're able to change these factors, make that part of their goals, so that they can, it's not on them at that last session anymore. It's actually from the first session, an expectation and a requirement from me as well as from them, so that they understand that they have to manage their condition on their own. And that's where, I ensure that that's not an ongoing conversation only, but also there's a channel for me. Sometimes when individuals are working with me, I have that wellness transition where I let them transition from my physical therapy one-on-one sessions with a home program. They progressed, made goals, they made changes, and they're doing well. At that point, I have a conversation with them. Are you okay to follow this program on your own, or do you need support? At that point, linking them to the support groups or like a wellness group that I have, it becomes very important. Or written routines, reminders, phone apps. Like I've used all of those to encourage adherence and ensuring that they're able to continue something in a very doable manner on their own at home.
That sounds great, Hina. And I guess that, we understand that if a person can do something for some period of time, some people say a few weeks, it becomes routine or a healthy
Yeah.
habit. But it also sounds like there is a handoff between the physical therapy expert and, let's say, a caregiver at home that might help the patient. Can you just say a few words about that?
Of course, I think caregivers, if they're available, become a very supportive factor. I've seen individuals where their caregivers are the ones setting up sessions for them or making sure that they follow through with the exercises, or they come into the session and are listening in and only, uh, pointing where things might be lacking, or sometimes the patient refers to the caregiver quite a bit. So I do think that interaction with the caregiver becomes very important. So I'm always including them day one. If the individual was not present in the first session, and if that is a factor of concern or has come up in my um, interview process, because I do ask them about their social history, occupational history, and everything, that's on their mind. I ask the person to show up the next session, or the at least at that end session, so that I have this continuity of care.
Excellent. I think we have one last question, Ina, and it has to do with the idea that there might be potential safety concerns that a clinician will have in mind when sort of moving from, a simple to a more progressive or intense regimen, but also with individuals who have significant weakness, imbalance, even sensory loss. So could you just give us some guidance there?
Yeah, and I think that is a huge challenge, especially when the person is transitioning to an independent program. But in my sessions, I'm always monitoring my person for their tolerance to the exercise intensity, for any other symptoms like acute sensory symptoms that could present when you're overexerting an individual, or overheating is another factor, or autonomic dysregulation, like a poor response of heart rate and blood pressure to the exercise progression. Sometimes there's falls because, the visual deficits and the balance deficits or the other balance deficits make them a little bit more, unsteady, and there's a chance that they're risking their balance and falling, or sometimes they're too confident because they're improving with the exercise session with me, and then now they're risk taking and then falling. So I think there's like a lot of factors that the clinicians should consider, and monitoring and progressing them through the regimen, keeping in mind that individuals can tolerate moderate to high intensity, but just educating them as needed to ensure that when they take these exercises home, they have a safe way of progressing through these exercises on their own, as well as within the session. And therefore, the handoff can happen well, for a home transition, completely home transition.
Dr. Hina Garg, thank you so much for your presentation and your great insights into practical applications of this type of regimen. Thank you so much.
Of course, thank you.
We'd like to remind everybody that this Grand Round session is eligible for continuing medical education activity. Please visit the Guthy-Jackson Charitable Foundation Education Center using the QR code shown here. Select the session you'd like to review and register. View the session, fulfill CME requirements, and then receive certification online. We're delighted to have presented many of the NMOSD Grand Rounds in the series. There's one remaining that will be coming up December 12th on emerging tolerization technologies and clinical trials. You can access the NMOSD Grand Rounds sessions, as well as other educational events, presentations, and media using the Education Center QR code shown here. We also would like to thank Alexion as one of the sponsors for this activity, which has supported the educational event by funding, and we're very grateful to Alexion. Likewise, this activity is also supported by an educational fund provided by Amgen. Thank you so much.